Yep.
There we go. And so without further ado, welcome everyone. We have Dr. Curry Herbert. Dr. Herbert, take it away.
Well, thank you very much. I will tell you that being from New Orleans, whenever I've gone to college and medical school, all these other places, everybody pronounces my name Herbert, but it's actually Hebert. I know that's a funny name, but it's pretty common in New Orleans. So when you come to New Orleans, I got you. I got you, because you're gonna have the best food you ever had. Trust me, I'll let your boy, right? So what I want to talk to you guys about today is not very long. It's just a concept that we as physicians, we want you to be able to get your medicine. We want you to be able to have care. It's very important to us. But sometimes, because we know in certain places, they don't have a hematologist. It's definitely not a pediatric hematologist. Some places don't have the access to medication. Some places people don't have the access to any healthcare at all. So there's got to be a way. So before COVID-19, there was always, oh, well, you could do some telehealth or blah, blah, blah. But nobody ever kind of really did it, right? But with COVID, there was no way around it, right? We had to know that we were going to have to take care of patients and we weren't going to be able to see them. So the whole telehealth concept became something that became in the forefront because that's how all of us received care. The issue, though, is that as a group, we had to think, well, wait a minute, people aren't going to be going back. It's not like, all of a sudden people are going to say, well, I'm just going to start going back to my doctor again, because people got very comfortable with saying, well, I don't actually have to go to a doctor. I could just pull up in the doctor's parking lot and get on my phone and I can see the doctor. That's a really awesome concept. All right. Well, when COVID is now theoretically, quote unquote, over, but it's not over, trust me. Then people say, well, why can't we just keep this thing going? So that's where our sickle cell patients, sickle cell warriors, and people that care for them, because thoroughly disenfranchised for so many years, that meant that there's a lot of doctors that whenever we have new treatments, which has been very, very rare, but in the last 3 or 4 years, there have been lots of new treatments. Hematologists and oncologists, those are the same, they are board certified in the same thing, hematology and oncology. Some of them choose to do oncology. Most of them choose to do oncology because that's where the money is. And some of them just obviously just like that better. Some of them are hematologists, but they do a lot of blood issues as well as blood cancers. But not many of them specialize in sickle cell disease. They see it sometimes as something that they do, but not the lion's share of their practice, which means you have to devote a lot of your time when you're doing something that's a lion's share of a practice. You have to devote most of your time in that type of research and that type of looking at the latest things. Well, when you have this situation going on where you have a patient population of 100,000, that seems like a lot. But in the grand scheme of the United States, it's not a very big number. So a lot of the doctors don't really know about a lot of things about the latest sickle cell therapies. So let's just say you are a patient and you saw something about a new medication and you go to your hematologist, right? And your hematologist says, I haven't heard of that medication. So you just have to sit there and say, oh, well, I guess I'll just have to wait until he can read the journal about it. That's not fair. So where we are now is telehealth and sickle cell disease, because we want you to be able to get the therapies that you need. So we're going to talk about the unmet need, telehealth and COVID, and then the telehealth pros and cons. The unmet need in sickle cell, right? Less than 30% of patients with adult sickle cell have access to a disease specialist. And that's a really, really big deal, right? So there's 70% of people out there that have sickle cell disease that don't get care. That's a lot of people. That's a lot of people. So what are they doing? Why are they not talking? Well, first of all, there's a stigma associated with ADHD. We know that. Also, ADHD. I have ADHD, actually, not really. I'm actually doing a conference there, and so it's a long story. But that have sickle cell disease, right? And so what do we do about that? The reality is you need to be getting care. There's a stigma associated with sickle cell disease, even at every level. Say you want to play a professional sport. You don't tell anybody you have sickle cell trait. Say you're at work and you don't want to tell anybody that you have sickle cell disease because you think they're not going to hire you because you're going to be off a lot because of pain crisis. So people don't want to do that. So 70% of people that have this disease aren't getting care. We don't know where they are. that is a tragic number, okay? And telehealth is a way that we can get around that, because what can happen? What can happen is that we can get to the point where you don't actually have to go to the doctor's office. And when you don't have to go to the doctor's office, that means that you don't have to be, it doesn't have to be, you don't have to be seen. Nobody needs to know that you have sickle cell disease, right? That's the first thing. And you can get your medicines. And that's a really important thing without having to go through all the trouble. Because if you, let's just say, I'm here and I'm sponsored by Emmaus Pharmaceuticals with the medicine called ENDARI. So let's just say, you heard about ENDARI. Let's say you're on this call right now and you heard about ENDARI. And you're like, I want to try that medicine. And then you go to your doctor says, I've never heard of it. Well, now we want to put the power back in the patient's hands. The power needs to be in the patient's hands, because that's not fair. We have been disenfranchised for too long, because it needs to be something where we get to the point where if you need a medicine, there needs to be a doctor that can service you. And we have seen that with telehealth, this is what's happening, because there's been an increase in telehealth across the country. Now, if you look at this, you see that where the telehealth pre-pandemic, you see that it was up and down, and then pandemic, it actually went down, a little bit, right? But if you look at the telehealth visits alone, then they went up after COVID. The in-person and telehealth visits themselves, mixed, went down, but the telehealth visits by themselves went up. So where we are is that people are ready for this. They're not going back from it. And now we see it as a prime opportunity, especially for sickle cell patients, to be able to call or log on to a portal, give the doctors that are on that portal, your information, your medical history, and then they prescribe the medicine. There's no reason why you have to wait for your doctor to get up to date on the latest information about medicine. Okay. So when you start looking at that, you can look at the institutions that you were in, right? The institution that you were in, did they have telemedicine before COVID? Did they? Have you ever used it? Well, what you have to remember now, though, is that if you go to our website, and a doctor that's going to be on behind me is going to tell you more about where you need to go. But the reality is that you can get it right now. You can go to the portal and you can actually get this medicine that she's going to talk to you about without having to go to your doctor. You could get it from Emmaus Therapeutics, and that's very important. The benefits is that you have increased surveillance, more frequent follow-up visits. You don't have to stop work. You can just go straight through. You can reduce your in-person visits, which means that you can actually see, not have to expose yourself to COVID-19 or other sick patients, because sometimes you get sick going to the doctor, let's be honest. And then also you could get the specialty care, because a lot of times now it's very difficult to get specialty care, because you go to your primary care and then it takes 6 months to get into a specialty care person. But for telehealth, especially with our platform, you'll be able to get into a specialist and talk to them about your medicine, talk to them about your care. It increases convenience. You have elimination of cost, reduce disease transmission, as we mentioned, flexibility. You can visit and you can have this visit anytime you want, and obviously reducing these in-person visits. The challenges, because nothing is perfect, right? Lack of a physical exam. So that means that the person can't lay hands on you. But if you're going to just get a medicine to get started, and you've been to your doctor in, let's say, 3 months ago, and we could get a good history from you, we could start a medicine, and then for your follow-ups, then you're going to just go to the doctor and get medicine anyway. So as opposed to putting their hands on you, the amount of time a doctor puts their hands on you in clinic now is very low. Lower reimbursements granted for the patient, for the doctors, but it's better for the patient. And that's what we're talking about here. We're talking about better for the patients. And obviously, if you don't have the internet, that could be a problem too, right? But when you look at this, you could have experienced pros and cons. But what you need to understand now is that where we stand, telehealth is something that is not going away. That's the first thing. The second thing is that you need to be able to get the medicines that you need. We have been disenfranchised for too long. So therefore, we want you to go to the Emmaus website. And if you want to try, which once you hear the data on this, once you hear about this medicine, you're going to want to try it. And if your doctor can't prescribe it for you, we can. And that's what I need to tell you today. So I'm going to turn this over to the doctor that's following me to talk to you more about the actual medicine itself. And then at the end, she's going to open it up for some questions. So thank you guys very much, and I appreciate your time.
Thank you, Dr. Corey. And we have next Dr. Cole. Dr. Cole earned her medical degree at Wake Forest University in Winston-Salem, North Carolina in 1995. She subsequently studied internal medicine, hematology, and oncology at Emory University in Atlanta, Georgia, where she completed training in 2004. And so without further ado, because I know she has an amazing presentation, we present Dr. Cole. Hi, Dr. Cole.
Hello, how are you all doing? Thank you for having me today. We're real tight on time, so I'm going to try to go as fast as possible. I'm going to talk to you today about sickle cell treatments that are available today and how we choose those treatments, how I choose those treatments. I won't just be talking about ENDARI, but I'll give you a overview of all of the treatments that we use so that we can give a fair presentation of everything that's available today. So I'm not going to go a lot into what is sickle cell disease, because again, we're tight on time, and you've probably heard treatments about or talks about that today. I'm going to try to get more into the treatment of sickle cell disease, but we know that sickle cell disease is a disease of the red blood cells, and that it causes the red blood cells to sickle. I just lost my slides. Hold on, let me see if I can get them back. It's a disease of the red blood cells that causes the cells to sickle, and the sickling result results in pain and results in damage to organs, and it causes anemia, causes patients to need hospitalizations and inpatient care. But fortunately, we have a lot of new treatments that prevent those types of complications from sickle cell. And while treating sickle cell disease in the past used to just rely on treating the end result of sickling, the hospital care, the treatment with bed rest and fluids and pain meds and supportive care, now we have new preventive treatments that allow us to prevent patients from getting as sick as they used to get, and treat them outside the hospital before the actual crisis occurs. So I've been taking care of sickle cell patients since 2004 in private practice here in Tampa, Florida. And I take care of over 100 sickle cell patients. And I used to have 7 to 10 patients in the hospital at all times. And now I take care of the same number of patients, but now I have between 0 and 3 patients in the hospital at all times. And so my specialty has gone from being an inpatient specialty to an outpatient specialty. And our patients, are living longer and living better because we have new treatments. But what I see a lot of times when people come to me from the community, from other hematology doctors, other oncology doctors, or maybe even from their primary care doctors, a lot of times patients are not on any sickle cell drugs. And a lot of times people are not having the benefit of this preventive medicine that we have available to us today. And so I'm hoping to help you all to understand what's available so that you all can seek out this care from whoever's taking care of you, whether it's a primary care doctor or a hemonc doctor. It's important that we try to prevent the sickle cell damage rather than just putting Band-Aids on it when it happens. So medications available to patients with sickle cell include Hydrea, ENDARI, ADAKVEO, and OXYBRYTA. Hydrea by far is the oldest sickle cell medication. It was first tested in sickle cell disease back in 1984. It was approved for adults with sickle cell in 1998, and then for pediatric patients in 2017. So Hydrea is the oldest drug available, and still we see a small percentage of patients are actually on Hydrea. Hydrea is the only drug that's known to have a survival benefit in sickle cell disease. It decreases severe sickle cell complications, such as pain crisis, acute chest. However, we still see a large number of patients come in who do not take this drug. So this, to me, this is a starting point. If I have a patient comes in newly on with sickle cell disease, the recommendation is that anybody who has 3 or more crises a year should be on this drug. So for me, this is a starting point to treating sickle cell disease. And the treatment dose is weight, although it's pretty much standard for sickle cell. Like most sickle cell patients take about 3 pills a day. The studies have shown that in adults, the Hydrea decreases crises by 50%. And again, in 2017 for pediatrics. Now, adult doctor talk more so about adult medicine, but I'll try to point out what drugs are available for pediatric patients and at what ages as well. So Hydrea is available for children 2 years of age or and older. It's the only drug has a survival benefit. These other drugs may have survival benefits, but we don't know because they're too new. And Hydrea has also been tested as an alternative to exchange transfusions in patients with sickle cell who've had strokes. So that's another use for it if you have a history of stroke and you're not able to get exchange transfusions, which is the standard treatment, then Hydrea is a possible treatment. Side effects of Hydrea include nausea, vomiting, loss of appetite, mouth sores, diarrhea, constipation, changes to the hands and the nails. However, I find that most people tolerate hydroxyurea extremely well. And I find that the symptoms, the side effects are pretty minimal. Next medication I'd like to talk about is ENDARI. And I talk about this next because this is the next medication that became available during my time of practice. ENDARI was approved in July of 2017 for patients age 5 and older. This is the first drug approved to treat sickle cell disease in patients. So even though Hydrea came out or was available, almost over a decade ago, it was just approved for pediatric patients in 2017, and ENDARI was already available for those patients at that time. Nonetheless, so ENDARI is one of my favorite sickle cell drugs. I like it because I think it's really well tolerated. I believe it's effective. It's more affordable than some of the other drugs that we use for sickle cell disease. And it's really, for me, was a drug that I think changed my sickle cell practice from being an inpatient practice to an outpatient practice. So for me, when we talk about how I treat, first drug I try to get patients on is Hydrea, because again, it decreases crises and it also has a survival benefit. It's been FDA approved for years. It's not very expensive. So most patients can get on Hydrea, and it's indicated specifically for patients who have 3 or more crises a year. ENDARI is a drug that I add on after Hydrea. So if a patient doesn't want Hydrea, for example, I would start with ENDARI. Otherwise, I would try to tell patients, first get on Hydrea. Let's try that for a little bit of time. I don't try to start a lot of drugs at the same time because a lot of the side effects overlap. And I don't want people to be confused about which drug is causing which side effect. So ENDARI works by helping to decrease the stress on the red blood cells in sickle cell. So it decreases what we call oxidative stress. That's above most people's head and not really useful information, but we'll still tell you how it works. But it helps the cell to gain flexibility, to travel through the blood vessels and deliver oxygen to the tissues, which is the job of ENDARI. But the most important thing that you all want to know about ENDARI is that it has been proven to decrease crises in sickle cell patients. It's very well tolerated. However, side effects do overlap with side effects from many other sickle cell drugs. So side effects can include constipation, nausea, headache, abdominal pain, back pain, And these are things that we see in most drugs. I find that although these are the listed side effects, I find that most of the side effects of ENDARI are in the gastrointestinal system. So in the ENDARI studies for ENDARI, they tested patients from age 5 to age 58. So ENDARI is approved for patients over the age of 5. And they found that there were fewer hospital visits for patients who used ENDARI compared to patients who were not with sickle cell who were not on ENDARI. They found that the hospitalization days were shortened. Meaning that there were less days in the hospital. And they found less complications such as acute chest in the hospital. So again, these are similar findings to what we found with Hydrea. But what I find is that the benefits are additive. So I start patients on Hydrea. If they do well with Hydrea, then I add on ENDARI. If I gave them Hydrea and they, sickle cell crisis disappeared completely, I might not need ENDARI, but that usually doesn't happen. So I often have to explain to patients that just like, most people take multiple blood pressure medicines, and people take multiple medicines for their diabetes or their rheumatoid arthritis or their lupus. People with sickle cell should take multiple medications for their sickle cell until we get the symptoms under control. So sometimes people think, well, if I'm taking ENDARI, I shouldn't take Hydrea, but they have different mechanisms of action. And that's one of the reasons why I mentioned the mechanisms of action, so you can understand that they work in different ways and they work very well together. Another drug that we have for sickle cell is OXYBRYTA. So OXYBRYTA is probably the 3rd or 4th drug that we had approved for sickle cell. This was approved in November of 2019. So we see that a lot of drugs have been approved for sickle cell in the last 10 years. The OXYBRYTA is a medication that we use specifically to improve the hemoglobin. The OXYBRYTA helps to decrease breakdown of blood cells in the peripheral blood and improve the hemoglobin, and it stops the cascade of that occurs that results in damage to blood vessels and tissues in sickle cell patients. But it's approved specifically because it decreases anemia. It's not proven to decrease sickle cell crises. And so that's important to understand because there's a different indication for this drug. And so if you have sickle cell disease and crises is not your biggest problem, pain is not your biggest problem, you feel tired all of the time and your hemoglobin is low and people are recommending that you get transfusions, then OXYBRYTA is a great drug to take in that case. And because I'm going to skip through some of these slides here, but most patients who take OXYBRYTA get about a 1 gram increase in their hemoglobin. So if your hemoglobin is normally 6, what I see more so in my patients is rather than just getting excited about the numbers, I see that people feel better. People feel more energetic. They say when their hemoglobin does drop, they don't feel it the same. And the side effects to OXYBRYTA include same thing, the GI side effects, diarrhea, abdominal pain, nausea, etc. So again, that's why we try not to start these things at the same time. The last drug I'm going to mention to you is ADAKVEO. ADAKVEO is an IV medication that patients can get infused once a month. This was approved also in 2019, same time that OXYBRYTA was approved. It's for patients 16 years or older. Specifically, it works in the blood vessels. It binds to a specific protein that decreases sickling by affecting the of the blood vessels and also the platelets. And in the ADAKVEO trial, there was 132 patients in the trial, and they found that they compared the ADAKVEO to patients who were not taking ADAKVEO with sickle cell. They followed these patients for 52 weeks, and they also found a decrease in crises. So again, for me, this is an additive benefit. I don't stop people from taking Hydrea when I add on ADAKVEO. If I have patients who are on ENDARI and they're on Hydrea and they're still having crises, then I add on ADAKVEO. Side effects for ADAKVEO are a little bit different. Some patients have aches and pains for 24 to 72 hours after the infusion, but usually we're starting this medication in patients who have severe crisis, who are in the hospital every month, sometimes multiple times a month, and they feel better with this medication than they do without it. And I have patients who have taken ADAKVEO who have not been in the hospital for a couple of years since they started taking ADAKVEO. So it does have a benefit but I tend to use it in patients who have more severe crises, who are having crises even with ENDARI and Hydrea. And lastly, I just want to say that there are curative treatments of sickle cell. So when you talk to your doctors about options for sickle cell, you should talk to them about curative treatments as well. I usually will recommend curative treatments in people who have more than a few crises a year and people who have life-threatening crises. So if you've been on this talk all day long, you may have seen the talk about bone marrow transplant and gene therapy. We do have bone marrow transplant available in our community. Gene therapy is still being studied. However, I understand that the study will be done at Moffitt for gene therapy. And so I've been sending patients to Moffitt for transplant. And you can see here, one of my patients here was cured from sickle cell disease, I think in 2018. He's now working as a real estate agent and thrilled to have life without sickle cell. He has 2 children and is doing so much better. He spent a lot of time in the hospital and in the office struggling with his sickle cell disease. And then I have the second patient here who also was cured from sickle cell with bone marrow transplant. So we have all these nice treatments for sickle cell, and I think that our treatments have really improved quality of life for our patients, but also consider the curative treatments such as bone marrow transplant and gene therapy. I think we're about out of time.
Yes, we are out of time. Thank you. I think, unfortunately, we do not have time for any questions, but people, please go inside the Hebert app. You're going to be able to ask your questions, and Dr. Cole and Dr. Corey will go in there and answer as many questions as possible. Thank you guys so much, very much for coming. Amazing presentation. Thank you guys. And we are going to be heading into the next session. So please, what you're going to do is you're going to exit out of this app, exit out of the app and go into the next session. Thank you guys.
Thank you so much for joining us, Dr. Cole, Ayer-Cole, and also Dr. Hebert. Thank you so much. I appreciate it. This talk was very interesting, and we will definitely have you answer those questions in the app. Sorry, we ran out of time.
Sure. Goodbye.
Thank you.
Thank you guys.